A very good afternoon. Welcome to you all after the lunch session to this course that we've been doing year after year, Phakic ICL Mastering Till Perfection. And we have a galaxy of speakers with us. Dr. Partha Biswas, Dr. Sheetal Barar, Dr. Pooja Khamer, Dr. Gaurav Luthra, Dr. Sanjay Chaudhary, Dr. Kamal Bandhu, and Dr. Krishna Prasad. Each one of them will be sharing their experience over decades of Phakic ICL use. So I would first like to invite our keynote address speaker, the guest speaker, Dr. Shreyas Ramamurthy, and this young dynamic surgeon would be talking on IPCL. So all to you, Shreyas. I would invite my co-instructors, Dr. Kamal Bandhu and all of them to be on the stage, please, with us. Kamal, please join in.
Thank you so much, sir, for introducing me and allowing me. I know these sponsored talks are never welcome inside an IC where you have such a elaborate and beautifully lined set of topics. But I'll try to keep it brief and to the point and talk about this topic given to me, which is IPCL one-stop refractive solution. So essentially, frankly, today, as all refractive surgeons, we must start asking ourselves, is there a patient where you cannot put a phakic IOL in? For almost every refractive error, any type of grade of refractive error, the type of refractive error, hyperopia, astigmatism, all types of refractive errors can actually be taken care of by phakic IOL. We have multiple Cochrane studies. We have multiple Cochrane studies showing that whether it is low, moderate or high powers, that they all work very well.
I think your laptop is not
projected. It's not connected, sir. That's why my introduction is running so long. Directly HDMI. Yes, sorry about that. So really, when we look at the IPCL and compare it to the ICL, which has really been around for more than 2 decades now, we have a very wide dioptric range in IPCL. Almost any power can be made, any spherical extent, cylinder. The wide customization that is available with IPCL is what really makes it stand out. It's a hydrophilic acrylic material, but I'm sure as the talks in the subsequent session will also show that it really doesn't make any difference. It has a very high extent of UVL biocompatibility, and we don't see any additional inflammation over what we see with the Collamer lens. There are some additional holes which are there in the lens for viscoelastic to drain out. It's a thinner lens in profile, and it also has a slightly higher mid-peripheral rise. And this is very, very important because we can still undersize this lens a little bit, but still have adequate vault. You will not end up with a low vault even if the lens is a little undersized. Now, you might be undersized because of the anatomical variation or between the white to white and sulcus to sulcus, or you might even be selecting in a case with a borderline ACD where you want to go one step lower as far as sizing is concerned to end up with an adequate vault and not have too high a vault. So we'll discuss about that a little bit more in the course of the talk. And one other important advantage is that it is customized to always be along the 0-180 degree axis. And that I think is another major advantage because when you're doing manual marking, this is the axis at which you have the least possibility of having a parallax error, and having all your lenses along 0-180 makes it very easy. Positioning it along again horizontally and not having to be in oblique is because you're really measuring the horizontal white to white and you want to place the lens horizontally. I'll talk about a little bit about the design of the lens. And essentially, for the optic size itself, you have a wide variety again. You can customize it, especially if the patient has a large mesopic pupil. You can even customize the size of the optic. There are additional haptic pads which again sit better in the ciliary sulcus, which again ensures that there is better stability, and these larger holes in the haptics sometimes can compensate for the oversizing, because they tend to press down. The lens is again very pliable and presses down, and you end up with a slightly lower vault. Looking at the landmarks itself, there is a small knob that you can see on the leading left and another small knob on the trailing right. These are the most important landmarks that you need to see. And this additionally, you have these two holes which generally want to leave it superior. Again, if the lens is completely flipped, that is in the reverse direction, you will still have the hole superior, but as long as the knobs are pointing in the leading left and trailing right, that's really the important point that you need to be seeing. The loading of the lens itself is very, very easy, and you can do it with both BSS or viscoelastic, and generally I just do it with saline, and all you have to do is, it's a simple butterfly cartridge, place it in the center, press it down, and while you keep it pressed down, just close the cartridge. This is important because you don't want any of the soft pads to kind of get caught in the cartridge when you're closing, because that can lead to tear of the lens when you're trying to push it. Apart from that, injecting and placing is very, very simple. Nowadays, we don't even use viscoelastics. I'll just speed it up a little bit. So the lens opens out very, very easily, very smoothly. You can either do it with irrigation or with viscoelastic, and usually it's a very nice, controlled, easy opening. And it goes through a 2.8 millimeter very, very easily. You don't even need a 3 millimeter incision that you normally require in an ICL. And again, rotating and placing it is simple. Only thing we need to do is that while you're trying to rotate, unlike a regular toric IOL, rotating along the axis will just lead to pushing the lens from side to side and doesn't really rotate. So retracting it towards the center and then releasing it, because it's there's very less space, unlike in a toric IOL. A phakic IOL has less space. So you may not be able to rotate it like a regular lens. Retract it towards the center and then nudge it towards the place where we want to place it. So sizing is what really is the critical factor, and looking at the white-to-white ACD is very, very important. And one additional advantage with the IPCL is that it is available in 0.25 millimeter sizing differences, and while 11 to 14 is available as a standard, you can even go for customized lenses which are larger than that. Seldom, very rarely would you require something lower than 11, because generally having a white-to-white less than 10 millimeter in a myope is less likely. But because it's available in 0.25 millimeter sizing, you really have options which are very, very good in terms of the sizing. And this is a patient who had an ICL and ended up with a little lower vault, and we are exchanging the ICL with an IPCL. Now again, because you have these 0.25 millimeter sizing, you can really customize. So instead of having just 4 options, you have a multitude of 14 options which are there, and according to the white-to-white of the patient, remeasure, and just you can have it at 1 millimeter, 1.25 millimeter, 1.5 millimeter over the white-to-white based on the ACD and the white-to-white of the particular patient. So despite the best of efforts, we may end up with a slightly lower vault, while with the Centraflow, you can observe vaults even as low as this, as long as the lens is not rotating. The chance of cataract is very minimal, but generally sub 100, in the long run, there is a slightly higher risk, though immediately there are patients, anecdotally, all of us have experience of patients below this where we do. But in these extreme low vaults, or more commonly in the higher vaults, which is now leading to a slightly shallowing of the angles, the angle opening distance is lower than what you would require as a minimum, then in those cases, you may have to go in for an exchange of the lens. Again, remeasure your digital and white-to-whites, and as well as with whichever optical device that you're using. Preferably in our practice, we generally use a topolizer or a Rob scan. And then subsequently, you can select the model. Like I said, it's available in 0.25 millimeter sizing. And the standard technique that I use for exchanging a phakic IOL is just after dilating, you can put in a little viscoelastic, just hook that one haptic out, and then just stabilize it. You can even use a Sinski in that hole, or even that is not mandatory. And then just hold it with a small forceps and then a hand over hand technique. Very often even that is not needed and it just comes out very easily. And then you can go ahead and place your additional lens. Cataract can occur very rarely, and this is an anterior subcapsular cataract. This is an older lens before the central lobe was available. So even in these cases, you can use a little bit of blue because the central capsule sometimes is a little fibrotic. And you can use the same 2.8 millimeter incision, remove the lens, and then go ahead and do your capsular excess and complete the rest of the surgery. The cataract itself is usually very soft, but just keeping in mind the same precautions that you would take for any high myope, you can then go ahead and complete the surgery and use a customized toric IOL if necessary. These are some initial papers that we published with our experience with IPCL and compared it with ICL as well, and the results were very, very similar. The presbyopic lens is also a wonderful addition to our armamentarium, and you have a near ad of 3.5, intermediate of 1.8, but again, based on the age and what you want to achieve for that particular patient, you have 5 variants which are available. So generally, what I like to do is in the dominant eye, go for a lower ad or the ad which the patient currently requires, and in the non-dominant eye to go for just one size, one power higher, so that this helps the patient over the next 5 to 10 years of their life as far as presbyopia is concerned. Because the lens is very close to the iris itself, the amount of glare and halos that the patients face with these presbyopic phakic IOLs is extremely low. It can be used in keratoconic patients as well, and this is just presenting quickly a brief of our experience with IPCL in keratoconic patients. And one thing that you need to keep in mind is that here you're really reducing the amount of anisometropia. It's not really the perfect refractive accuracy that you're looking at here. And while plus or minus 1 diopter was 90% of the patients, what is more important to see is that 40% of patients had a gain of 1 or more lines as compared to the best spectacle corrected visual acuity. And this is essentially because of reducing the amount of anisometropia and anisoconia, and because of the image being closer to the nodal point of the eye, the lens being closer to the nodal point of the eye, there is no minification of the image, and therefore the best spectacle corrected visual acuity also improves. It works in both low and high astigmatism, even greater than 4 diopter of astigmatism. It was very good. ICL, IPCL both worked very well. It worked in decentered cones as well. As long as the best spectacle corrected visual acuity is good and the patient is adapted to their cone, it works extremely well. Only thing we need to keep in mind in keratoconus is if the patient has a high Kmax, above 52 or 55, you can have a falsely high anterior chamber depth, and this can lead to a little higher vault and pupillary capture. So what we do whenever the Kmax of the patient is high, we just undersize the lens by 0.5 millimeter and then go ahead and implant, and this works out very well in these keratoconic patients as well. So really appropriate case selection, patients with good best spectacle corrected visual acuity and sizing gives optimal results even in keratoconic patients. It can be used post-DALK as well. I'm just for paucity of time, I'm just running through this. It can be used as a piggyback lens as well. Frankly, there is almost no indication for which you cannot use an IPCL, and really whatever extent of refractive error that you're correcting, I truly believe that IPCL is a one-stop refractive solution for all our patient needs. And really, we have to keep wondering as you open a new center or a brand new center, whether really an excimer laser is required for any new practice. Thank you so much for your attention.
Thanks, Shreyas, for that wonderful lecture. And I think that covers the entire IPCL and the IPCL family. So thanks, and we'd like to continue this session. I'd like to invite Dr. Pooja. Please be on the stage with us. Sheetal, thanks for coming. Please be on the stage. Is Dr. Partha, Dr. Gaurav, Dr. Kudlu here with us? So, नहीं आ रहा है? ये दूसरा लगा था, Thunderbolt. अरे come on. इसको डायरेक्ट लगा दो, आपको इसमें लगा दो. नहीं, इसमें लगी. अच्छा, ठीक, लगा. So I'll be running you through some good video collection, right from the basics of ICL loading, ICL insertion, and some tricky situations where actually the hand maneuver and a play with the injector and the wound can actually help you save your life a lot of times. So, sound लगा दीजिए. So this is actually what loading to me is. So this sponge, I never take any metallic instrument while taking this ICL out of the bottle and putting inside the cartridge. So this is the reverse as against the IOL that we load. And be careful that the 3 holes that you see have to be in line while you are actually pushing the lens inside the eye. So what actually I mean by this is, so the standard 1.1, 2 side ports is my standard. I would put in a drop of phenocaine, no proprietary interest, put in some viscoelastic. HPMC stands, and this is very important. The incision always has to be marked. I always mark exact 3 millimeter because I don't want a wound assisted and a clear corneal incision. And then this is how the lens system goes in. And once we are injecting, what I'm looking at is the 3 holes here. So the optic has these 3 holes, and if these 3 holes are in line, so line is like this, they are aligned, never ever you will have the ICL going upside down. Very gently you have to tap, don't be in a rush to push in, and let the lens unfold. Push in, go on top of the lens, push in some amount of viscoelastic so that you have a space between the endothelium and the lens, and gradually tuck. So tucking has to be at the junction of the plate and the optic. So never touch the optics here because this is the thinnest part and the most delicate part of the phakic lens. So tucking, the trailing could be through the main wound or the side, and then you can orient a viscoelastic wash. Just watch, this has to be avoided. The cornea never needs to be folded here. So a very gentle aspiration of the viscoelastic. Now just watch, this lens goes inside. I'm just observing how the lens is unfolding, and the lens has a tendency to go the reverse. So I just smartly go in and the manipulator and just push in, the lens goes in the right manner. So you have to observe how the leading part of the ICL goes inside the eye. Be very, very slow, be very gentle, let the lens unfold so that maximum part of the lens goes and inside opens up. Sometimes the edge can get stuck inside the wound. If you observe carefully, I was trying to forcefully push and the leading part is stuck onto the wound. So now watch how the lens will unfold. So you actually need to withdraw, reload, and don't try to push the lens inside because the lens can get torn off or you can have an upside down lens. Never overfill the anterior chamber. It should be just adequately. And this is what I want to describe here. It's in your hand, the rotation. So it could be clockwise or anti-clockwise, the injector. So you should always have a good hold and a good grip onto the injector delivery system. And then you can slowly, while pushing, you can just manipulate the lens clockwise or anti-clockwise rotation so that the lens unfolds in the correct direction. So never be in a haste, just watch. So the lens goes 1/4, but then you can't push in. Withdraw the lens, reload, and then you can re-inject the lens. Sometimes if the lens, just watch. This is not the Collamer, but this is a hydrophilic lens. some amount of extra effort has to be applied. I usually am not in a favor of hydroimplantation of these lenses, and I would always push in. Just watch carefully. The 3/4 of the lens was in, and suddenly I withdrew the injector, so the lens is stuck. So rather than pulling, you should gently push the lens, and you can easily escape from this situation because the lens, most part of the lens is in, and the lens can. Now this is a quite interesting patient, non-dilating, around 4.5-5 millimeter pupil, and we thought of using a pupil expanding device, but unfortunately we were lucky enough to have the lens inside the eye. So you don't try to push the lens directly underneath the iris. Let the lens unfold in the anterior chamber, push in viscoelastic, let the chamber deepen up, and then you can slowly manipulate the lens inside the eye. Undue stress on the zonules can sometimes break them open, so be very, very gentle while pushing the ICL inside the eye. So be slow, because this lens can go either ways, and yes, it's in the correct plane. Now this is again, if you see, the injector has come up and it's halfway inside the wound. Better it is to withdraw the lens, reload, and then push in the lens. So you have to be gentle in these situations, because the moment you try to just watch the lens again, maybe not more than half, and then it goes, and then you can have it in the correct plane. Again, the lens has not been loaded properly, so the leading edge was caught but carefully delivered. So these are a gamut of situations which you can face. Just watch again. The lens leading haptic has been caught, and there is no point in pushing the lens. It's better to withdraw and see the lens is caught, because it's a very, very delicate. The central part of the optic is just 50 microns. So you have to be very, very careful you don't tear the lens apart. Again, the same situation where the haptic, the leading plate has been caught, and watch how clumsily the lens opens up. So loading is a very, very essential part for a successful implantation of an ICL surgery. It should always be done under the microscope. Now this is a patient, keratoconus. We centralize the cone using Intax on the Smile Pro platform, and then we are taking the ICL inside the eye. It's a toric lens, and most of these patients, now it's not an off-label indication, but it's an indication for ICL in most of these toric patients. So right from low myopia. Now this is a very interesting case, came to us for a second opinion. The patient had an ICL surgery a few years back, but the surgeon couldn't realize that the lens was reverse. So if you see here very closely on the slit lamp, the lens, you can see it's at the concavity part on the anterior. There's the hole, so it gave us a clue that's an ICL, and there was a cataract inside the eye. This is how the picture looked like, and there was a ring sign where the lens was snugly sitting onto the natural lens. So a routine OCT, this is a patient who had a trauma post ICL, and there was a capture. So just irrigation aspiration. Be careful, the air bubbles can sometimes be disruptive, and just release and pushing this plate behind could solve the entire misery in this patient. And this was 5 years after ICL surgery that this patient had an injury. So the lens goes reverse. Don't panic, push in viscoelastic, and with the same set of forceps, you can just gently pull the lens from the same wound, reload and re-inject the lens. Sometimes you can have unexpected rotation of the ICLs. So I think that is one situation where under hydro you can actually rotate and manipulate the lens to the desired axis. So if the vault is low and the lens tends to re-rotate, then you need to exchange the lens to a one size up. So measurement of the vault is very, very essential in patients where you have repeated re-rotations. So this is one such patient who came to us after 2 years and had almost 90 degrees of rotation but could not settle, so we had to do a one size up for this patient. Sometimes if you have cataract, the lens is very simply push in viscoelastic. You can just push out the lens, you just pull it off. The IL master gives you the same reading and the cataract can be performed in the same way as we do on the routine cataract surgery. So thank you very much. And now I'd like to invite Dr. Sheetal. Do you want to go first, or Kamal? Dr. Sheetal, I think she's not well, so she requested. So on to you, Sheetal, and she'll be talking on choosing the right patient and the right sized lens.
Good afternoon, everyone. I'll be talking about choosing the right patient and the right sized ICL, giving more emphasis to the sizing. So no financial disclosures. So the right candidate. So patients should be aged between 21 to 45 years. Their refraction should be stable, which means that they should not be beyond more than 0.5 diopters change within the past 12 months. So it corrects myopia. So I'm talking about ICL particularly. It corrects myopia from -3 to -20 diopters, hyperopia up to +10 diopters, and astigmatism up to 4 diopters. Patients should have an adequate anterior chamber depth, which should be measured ideally from the endothelium. Ideal would be a 3 millimeters ACD depth, but a minimum of 2.8 cutoff should be respected. So patients should have healthy eyes besides refractive error, and one should rule out moderate to severe glaucoma, active uveitis, cataracts, or retinal detachment. So contraindications, of course, would be a shallow anterior chamber depth of less than 2.8 millimeters, shallow anterior chamber angle as measured on gonioscopy less than grade 2 would also be a contraindication, pregnancy or lactation, uncontrolled diabetes or autoimmune diseases, and also eyes which are not meeting appropriate endothelial cell density criteria, which has been suggested by ICL, by Star Company, and this should also be followed. So coming to the sizing, now conventionally if you see, ICL sizing has been determined basically on the basis of the horizontal wide to wide diameter and the anterior chamber depth. So these variables are then entered into the manufacturer's nomogram, which is available, and this is the OCOS nomogram which is used. So with the wide to wide and ACD, basically the wide to wide is an external measurement that is serving as a surrogate for the internal ciliary sulcus. Now the ICL is actually sitting in the sulcus, But manually from outside you cannot measure the sulcus, so white to white serves as a surrogate for that. And it is based on the assumption that the sulcus size is 0.5 millimeters larger than the white to white. So it accounts that and calculates the lens power. Now, where the fallacies arise, this could be, first and foremost, it could be just a measurement error. Now, considering that the limbus itself is a 1.5 to 2 millimeter gray zone area on both the sides, it itself can introduce an error of up to 4 millimeters if it's not measured correctly. And the measurement would also depend upon how and from which point are you measuring the white to white, the inner or outer limbus, which is selected as a starting point. So for best reproducibility, it is advisable to measure the limbus from mid-gray zone on one side to the mid-gray zone on the other side. So that is with manual caliper. So the manual calipers have, of course, some advantages, that it's low cost. However, the accuracy can suffer. So now you have the digital calipers also. With the digital caliper, the accuracy is better. However, both the methods are operator dependent and thus can have subjective variations. Now, we also have automated systems such as the OBSCAN 2, the IOL Master 700, the Pentacam, and now the MS39. Now, the advantages of these automated devices is that they provide high precision readings, and they are less operator dependent and provide much more comprehensive data alongside the white to white value. But of course, they are expensive and there can be device specific biases also. Now, if you just compare the average values of white to white measured using the different ICL sizing methods, using the different techniques of measuring the white to white. So the manual method of Castrovizio caliper, it actually gives you an average value of around 11.94, which is the largest amongst all methods. The digital can be slightly smaller than the manual. The Pentacam actually gives you the smallest mean of all. The IOL Master gives you a mid-range value. The MS39, which I am currently using, is actually, if you see, is quite close to the value provided by the digital caliper. And the OBSCAN, of course, is considered to be very accurate, but now because it's not available commercially, so the availability is limited. Now, what was the need for newer ICL formulae? Now, there were some limitations with the traditional methods of white to white calculations. And this is, as I said, the white to white does not directly measure the sulcus diameter, which is the actual space where the ICL will be implanted. So this can lead to potential inaccuracies in the sizing. And so you can have post-op vaulting issues, either a very high vault or a low vault. And also it has been found in many studies that the correlation between the white to white corneal measurements and the internal sulcus to sulcus is also weak. Basically, it's not that if you predict the white to white and if you measure the white to white, the sulcus to sulcus will always be 0.5 diameter larger. So that's not the case in every eye. So they do not correlate very well. Sometimes it can be smaller also. So you can end up having unpredictable outcomes. So the success rate with the star OCOS formula has been found to be 66.4%, which means that you can get a vault of the accurate size, which is 250 to 750 microns, in about 67% of the cases. However, about 33% of the cases were shown to fall outside this normal range. Also, why new formulae were developed? This was because there were advances in the imaging technologies. So now we can measure direct sulcus measurements through anterior segment OCTs, through UBM, and now we have also some new parameters such as the crystalline lens rise. So when you use only the white to white and with the OCOS formula, there could be some eyes where you could have some, red flags. So you should be very careful in these eyes about selecting the size. So these are extremes of the refractive errors, high myopia, high hyperopia. Extremes of the chamber depth, very shallow and very deep chamber depths, irregular corneal shapes, post-refractive surgery eyes, post-LASIK, post-PRK, ethnic variations, thick or highly curved crystalline lens, which is the high crystalline lens rise or the CLR, very narrow or wide sulcus angles also, and as well as pupil size extremes or decentration. So if you encounter any of these conditions, so you need to be much more careful if you're using the conventional method. So the clinical implications in these eyes could be, if you see the vault error magnitude, a 0.5 millimeter ICL size error would actually shift your vault by 200 to 300 microns. And if these are red flag eyes, this could actually push it to outside of the normal range, and you can end up getting a very low or a very high vault. So the success rate of the OCOS formula, which is 66.4, will actually drop further in these extreme conditions. So what is recommended is that in these eyes, it's better to supplement the white to white with the direct STS, which you can of course measure with the UBM, or the angle to angle, which is measured using the OCT, and CLR and some of these newer biometric methods, and using the modern formulae. Also use better screens better tools for screening, such as the preoperative OCT like Anterion, MS39, UBM, or shine plug imaging, to identify these eyes with red flags for proper sizing. So this is a picture showing UBM sulcus to sulcus. So UBM is high frequency UBM with wide scanning field. It enables the direct measurement of the ciliary sulcus. And this is how the anatomy of the ciliary sulcus looks like with the UBM. So you can see the white to white on top and sulcus to sulcus. So you can see actually in this eye the sulcus to sulcus is wider, but this is not always true for every eye. So crystalline lens rise, or CLR, or simply the lens rise, is nothing but it is another biometric measurement that quantifies the anterior protrusion of the natural crystalline lens in the eye relative to a reference plane. So what is this reference plane? This is essentially the line connecting the angle recesses or the sulcus to sulcus plane. So you can see on both sides, the sulcus to sulcus, there's this line that joins, and in reference to this line, how high your lens is, the crystalline lens is. So based on these new parameters, you have now many new formulae, such as the KS formula, the NK formula, SN formula, the Lasso suite, and the WH formulae. So most of these newer formulae have actually shown that the success rate of achieving successful vault is comparatively much higher compared to the star OCOS formula. Why not 100%? Why we do not get 100% successful vault in all eyes? That's because even with the newer formulas, you can still have some variations which may be related to measurement inaccuracies, unpredictable anatomical variations. They can be post-operative changes, where the haptic settles, healing, formulae imperfections, formulae are still getting refined, and surgical and anatomical clinical variables. So even with these high success rates, 15 to 20%, 25% of the cases will still have irreducible challenges. However, if you use real-time intraoperative vault measurements, and also if ICLs are available in finer increments of, let's say, 0.1 mm, that might push the rates closer to 90 to 95%. So choosing formula, choose the proper demographics, because not all formulae are for all ethnic races. And also if the patient's age at the time of ICL implantation should be considered. So those factors, those formulae where CLR is used, so the CLR may continue to increase over time due to natural lens aging. So this should also be kept in mind. So my protocol briefly, I'm using now MS39, because MS39 is highly accurate for white to white measurements with a repeatability error of only 0.05 millimeters. And it agrees very well with the devices like Pentacam, which most of the surgeons are now using. the accuracy being within plus minus 0.2 millimeters. In irregular corneas, however, the accuracy can slightly vary, but still remain strong with the variation of within 0.2 millimeters. So this case had a white to white of 12.61, and I just used this reading. And with the OCO's formula, it suggested a 13.2 lens, and the post-op vault is 596, which is very much within the normal range. Similarly, this patient has a white to white of 11.9, and with the regular star formula, I achieved a lens, the vault of 600 microns, which was fine. So to conclude, basically all currently employed methods, including those based on white to white, STS and ATA, for predicting vault and selecting ICL sizing, produce acceptable results. However, with the newer formulae, experienced surgeons should investigate their personalized methodology. What works best for you for patient evaluation and ICL selection that best aligns with your personal preferences based on your experience, which formula you feel is giving you the better results, what diagnostic technology you have for white to white and other biometric assessments, and also what analytical tools you are familiar with. So it has to be a personalized methodology for every patient. Thank you so much for your kind attention.
Thanks, Pooja, for that wonderful talk. Meanwhile, I'll request Dr. Pooja to be there on the stage. Any quick question for Dr. Sheetal? Can I have a question, Sheetal?
Dr. Sheetal, I think excellent presentation. A couple of points I'd like to mention, especially when you talked about the CLR. I remember we were one of the first people 11 years ago pointing out that this could be an important component. Yes. Because one thing I've noticed is yesterday also in a session, a suction course, we had a patient who had a great vault, but the lens would keep rotating. Patient had a vault of 600, the lens rotated. We changed the lens, put a 900, lens rotated. And that's when I went back to the drawing board and found there was a CLR of negative. So these are the patients you should look out for, where your CLR doesn't go into the minus because the lenses will keep rotating.
So then some of these newer formulae, they are available in Anterion and KZR2, the NK formula and the KS formula. So they directly measure the STS, the angle to angle, and also a CLR, so it gives a better predictability.
Thanks, Sheetal. All to you, Pooja.
Thank you, sir. Thank you, Dr. Sonu, sir, for inviting me in your instruction course once again and giving me this opportunity to share experience on Phakic IOLs in low diopters against LASIK and lenticle procedures, or PRK. So we all know that myopia, hyperopia and presbyopia is on a rise, and nowadays a lot of people want to opt for a cosmetic refractive surgery where they don't have the need to wear glasses. Now, if you just divide the myopia, you have 41% of the patients who are low myopic, which is less than 3 diopters, and then you have 59% who are high myopic and more than 59%. So like this is how it happens. So technically your 40% of the crowd which is going to come to your clinic for refractive error surgery is going to be 40%, and you have to choose the right surgery for them. Now, whenever it comes to refractive surgery, especially low myopia, you always have two options. You have laser-based procedures like LASIK, trans-PRK, SMILE, or you have lens-based surgery to correct the refractive error. Now, low refractive errors always, or whenever a patient has a healthy topography, laser-based procedure is the choice of procedure. However, and it does give us refractive outcomes. But if you speak from an economical perspective, it can be expensive, and because it requires an extensive diagnostic and surgical setup. Sometimes, of course, when you do a laser surgery, it is irreversible in the cornea. Once you have done the laser, you cannot go back and give back the patient the shape what the patient had. So it's irreversible. And also, a patient suitability may be a stumbling block, which I'm going to come in my next slides. Whereas when you see the lens-based refractive surgery, which is the Phakic IOLs, we all know that they do give us good outcomes. They are much more predictable in terms of contrast sensitivity, your safety, efficacy, and your quantity and quality of vision. So, and it is also cost effective because most of us here are cataract surgeons, and we do have a basic cataract setup. So it hardly requires anything more. It's just a tomographer and maybe a digital caliper, but we can do most of the stuff with our existing cataract practice, so it's cost effective. Let's say tomorrow the patient is not happy with the lens-based refractive surgery. It's a reversible procedure. But the biggest challenge here, of course, is that it leads to increased incidence of cataract. But with today's era, if there is an incidence of, there is a cataract, there's a good way to deal with it with the best of lenses available to our armamentarium. So, of course, when it's a lens-based surgery, there's no question if the patient is young and if everything is fine, phakic IOL is the way forward because it does preserve the accommodation. It has a broader range, the rapid visual recovery, and high predictability rates. Now, for low myopia, you'll always have these 4 options: trans-PRK, LASIK, CLEX, and phakic IOL. So let's go step by step of what the advantage and disadvantages are for each of the procedures. For trans-PRK, it is a bladeless single-step procedure. It has less biomechanical alterations, and if we all know that the incidence of ectasias with trans-PRKs are minimal or nil, and whatever biomechanical strength is there today, it's going to be there after surgery most of the times. And the corneal nerve hemostasis is very well maintained. But of course, the patient do have, they're always scared of getting a trans-PRK done because it does pain and there is a little bit of discomfort, especially in the first 24 hours and until it heals, which may be 3 to 4 days. It is slower recovery in terms of your quality of vision and sometimes quantity of vision. And there's always the most dreaded complication you can have is chances of haze. So trans-PRK is a very good option for low myopic patients, but you have to understand the pros and cons for the procedure before advising it to the patient. And knowing the personality of the patient is the key of it. Now, when it comes to LASIK, all of us are very comfortable with it because it has the wow effect on post-op day 1. 99.99% of the times you don't have to worry because the patients are happy and that's what they want, day 1, good quality and quantity of vision, and it's a quicker recovery. However, it's a flap-based complication, so if you have any patient who's into contact sports or army or anything, you cannot technically offer this procedure to them. The aberrations do get altered, and if it's a very high myope or if it's a very high cylinder, sometimes the contrast sensitivity can drop. It's a flap, so it drops your biomechanics by at least 20%, and then further based on the refractive error, you correct. Low refractive error correction, lesser change; higher refractive error correction, more change. And one thing you have to understand is it's irreversible. So if tomorrow your patient is unhappy, you have to deal with the patient and give them the best possible option but it's irreversible. When it comes to CLEX procedure, again, it's better than LASIK but worse than trans-PRK in terms of biomechanical alterations. It does avoid flap-based complications, so you can give it to your sports people or your people in army or in any with a little bit lower, thinner cornea, and you can do an extra procedure. However, sometimes when it's a very low myope and with newer technologies coming in, sometimes the lenticule is very thin and it makes it difficult for us to identify the plane, remove the lenticule, and sometimes there is a fear that the lenticule may be torn or retained, especially in the edges in very thin corneas. And like LASIK, it is irreversible. But when it comes to phakic IOL for low myopia, I think whatever challenges we have with other procedures is not there here, and but you have vault-related complications, but we do have option of exchanging the lens, which is not the best option, but if something happens, you can do it. So why phakic IOL sometimes for low myopia? Because it's a non-ablative procedure. It is suitable even for thinner corneas, and it's reversible in nature in true sense as compared to the other laser-based refractive surgeries. So now, how do I use this for my benefit? Let's see a few case examples. These are 2 patients. One is posted for LASIK and the other is posted for ICL. Both have 6x6 vision, but this patient who's undergone LASIK has difficulty in focusing for near because there is a little bit of change in his aberrations and he's not able to adjust to it, which has led to convergence insufficiency, and he has headaches. Whereas because we are not altering anything in the cornea or aberrations of the cornea, the patient with ICL is 20/20 with no photic phenomena. So what could be the reason for this? As I already mentioned, in LASIK, there is always a change in aberrations which may alter your depth of focus, whereas in phakic IOLs, your depth of focus is maintained. Now, whenever you have a low refractive error, when you do your topography and biomechanics, whenever you have a skewed surface like what you can see here, It's not a symmetrical bow tie. There is a little bit of skewing present here on both the eyes, and biomechanics is also on the borderline side. So in such kind of cases, the only two options are trans-PRK or phakic IOLs, but if the patient is not willing to take the discomfort and pain, then phakic IOL is the only option for this patient. This is the patient where everything looks fine. You can go ahead and do the surgery, but what if your patients have keloid? Do you want to take a risk by doing any laser-based procedures? I think the ideal way, as we have more predictable results with phakic IOLs, it's better to avoid any laser-based procedures and go for phakic IOLs, especially with patients with keloid tendency. And if the patients have any dry eye related issues, like everything is fine again here, but the patient has burning and irritation. Whenever they complain of burning and irritation, or especially they say that whenever I wear contact lenses, I have a lot of burning, irritation, itching, that there may be an ocular surface issue present here, and if you do a LASIK on them, it's just going to worsen. And these are the patients where you probably would avoid a laser-based surgery and go ahead with a phakic IOL, because phakic IOLs are known to not worsen the dry eye after the surgery as well. I'm going to skip the videos because Sonu sir's presentation was very good. And last but not the least, whenever there's a very thin cornea, especially less than 470 microns, always go ahead and do a phakic IOL without thinking. So to conclude, phakic IOLs are good options when it comes to low myopia, because it has minimal alteration in terms of aberrations, depth. It maintains the depth of focus. It is a viable option with patients with irregular corneas or any topography changes or poor biomechanics, and they are a safer option with patients, especially when patients have ocular surface disorders. Thank you.
Thank you, Pooja, for that wonderful talk. And I think that clears distinctly between the three procedures. What's the lowest diopter on the ICL that you have done?
Yes.
2.5 diopters.
Yeah.
So I think that pretty clearly spells out that even for low diopters, ICL is quite a safe surgery.
I've done patients where the cylindrical error is a little bit on the higher side, but the sphere is 0.75. But when it comes to just plain sphere, 2.5 diopters. Okay. But for cylindrical power, the sphere 0.75 is what I've corrected.
That's quite reassuring.
Yeah, because I think whenever there's a high cylindrical error like 2.72 or more, we've burnt our hands doing especially with borderline biomechanics and thin corneas. If you do a trans-PRK, there's always a very high risk of peripheral haze. So phakic IOLs are peaceful.
But the only concern is their rotational stability and their placement right bang on the axis. And I'm sure with your hands and with all the devices latest, I mean, the results must have been like.
You're absolutely right, sir, because especially for such low myopic patients, sphere or cylinder, you have more stress because they're technically able to see 618, 612, and if there is a rotational issue, then they are even worse. I think for those patients, my option would be IPCL first, because you just keep it at 180 degree, and probably not ICL is what I would probably do it in my clinic. I do that.
Thanks, Pooja.
Thank you.
Sonu, I'd just like to add something. My first exposure to a low-power phakic lens was a couple of years ago. I had a couple from the American Embassy, husband and wife, both were Americans, 2 and 2.25 diopters approximately both, and they both asked for a phakic lens because they said it's reversible. And that's when it opened the box for me that, okay, I can open these options. So I open these options to patients who come to me for a refractive correction, even at a lower or moderate power. I tell them, here is a reversible procedure. Here is a procedure which costs less, but not reversible. Take your call.
I would just like to add one more point. Whenever there is a family history, first cousins, especially with family history of keratoconus, strictly avoid any laser-based procedures. I think I should add that for, yes.
So in the middle of the session, we have a wonderful keynote address from our guest faculty, Aure Roston. She'll be talking on managing the unhappy refractive cataract patient. All to you.
Great. Thank you so much. Thank you, sir, and thank you for the opportunity to speak here. I have no significant financial disclosures. The first thing that we need to decide is, why is the patient unhappy? Is it a quantity or a quality of vision issue? Do they have dysphotopsias? Is it decreased contrast? Is it distance vision that they're concerned about, near vision? And also the timing. Have they been unhappy since the cataract surgery, or did it happen weeks to months later? Of course, evaluating the patient, we do the usual evaluation, all the diagnostics that we normally do. You want to pay careful attention to higher order aberrations and also do a very, very careful slit lamp exam, of course, and a very, very careful refraction. Well, why is the patient unhappy? If it's a quantity of vision issue, and this we ascertain by refracting the patient. If a simple good refraction fixes the problem, and I would say is that you actually have to do not an auto refraction, but an actual old school refraction, because auto refractions in patients, especially with multifocal IOLs, are not going to be accurate and you're going to end up over minused. If the refraction fixes the problem, then it's really pretty straightforward. If it's greater than a diopter, I prefer IOL exchange. And if it's a small residual refractive error, less than a diopter, then PRK or LASIK is going to be your friend here to fix this. If it's an axis of astigmatism issue, then potentially a rotation of a toric IOL. So you really want to ascertain, is it a quantity versus quality? If it's a quality of vision issue, then it gets a little bit more tricky here and a little bit more in depth to decide why is the patient unhappy with their quality of vision. If it's a negative dysphotopsia that they're describing, most of the time this improves with time. And I reassure the patient that over 90% of patients who are experiencing negative dysphotopsia, by the time they're 6 to 12 months out, they're not going to notice it anymore. And so there I just really give a tincture of time. If they are still unhappy a year later, then you can decide to do a reverse optic capture or even an IOL exchange for a 3-piece silicone lens. If it's a positive dysphotopsia, glare or halos, and if it's been present since the surgery and there has been no improvement, then an IOL exchange may be your best bet. You, of course, want to notice, is there any corneal pathology? If there's anterior basement membrane dystrophy or a corneal scar, keratoconus, then you need to address that first. And if it's floaters that are really bothering the patient, if everything else checks out and it's floaters, then you can consider a YAG vitreolysis or pars plana vitrectomy for floaterectomy. We have our toolbox here. All of these things are available to us, and you have to decide what is the best modality to treat your patient. The most important thing, though, is to listen to the patient, decide what is it exactly that they're complaining about. Is it the quality versus the quantity of vision? And so we'll go through some cases here, and these are actual cases. This was a 61-year-old physician, a colleague. He had LASIK way back when, little mini monovision, and came to me. We decided on an EDOF lens. I implanted the Alcon Vivity lenses, uneventful femtosecond laser surgery, a week apart. I treated pre- and post-operatively, dry eye, ocular surface, everything. Here was his vision and his refraction, and he did have some ghosting in the right eye. Looking at the tomography here, looking at the pentacam, he did have some irregular astigmatism, which was unchanged from preoperatively, and I thought, well, this must be the thing, so let's go ahead and do a Contura topo-guided PRK. So I went ahead and I did that, and yay, 20/20 in the right eye, minimal refraction, vision in the left eye, which had some myopia, was unchanged. And so here he was, 20/20, J2 at near, and you would think, congratulations, you did a good job. Well, not so fast. The patient was happy with his near vision, but he stated that with his right eye, he felt like the cataract was back. He did have significant PCO. I did a YAG capsulotomy in both eyes, and he came back 6 months later after traveling, and he was still 20 unhappy. He had 20/20 vision in the distance with both eyes, 20/20 in the right eye, 20/40 unchanged in the left, and so what to do? Well, before we get to what I did, we'll go over another quick case. Another patient, this was the mom of one of my kids' friends, a 64-year-old hyperope. You could see here, nothing too exciting there. I did uneventful surgery on her with multifocal lenses. Again, 20/20 in the distance, J1 intermediate and near, and you're thinking this is a win, so excited, congratulations, but again, not so fast. 20/20 and 20 unhappy. She said, I know that you told me I'd see some glare and halos, but I wish the cataracts were back. 4 months later, because of course they always tell you in the sales booths, oh, they just need to neuroadapt. Well, sometimes they do need to neuroadapt, but a lot of times they just don't, and they're just unhappy. And so gave her about 4 months, no neuroadaptation. Yeah, the halos were a little better, but still miserable. And so for both of these patients, what I ended up doing was an IOL exchange. I exchanged the multifocal for a light adjustable lens. I know that you don't quite have that technology, I think, or maybe you're just getting it here. But essentially, when I do my IOL exchanges, I like to cut the lens. I don't cut all the way through, I just cut partially. Oh, something going on here. Seems a little stuck. There we go. I cut partially through, and then I just twist and turn the lens out, and then, okay, it's always convenient. And then, thank you. And then remove the lens there, and then go ahead. I just want to advance the video here. And remove that lens, and then basically I'm going to implant the light adjustable lens. It goes in, it's a 3-piece lens, and it fits nicely. You can put it, the nice thing is that you can place it either in the bag or in the sulcus with optic capture. Both of those ended up 20 happy. Case 3, this is a 67-year-old gentleman who complained of blurry variable vision since surgery. You could see here he had some astigmatism, no previous ocular surgeries. And when we look at the slit lamp as well as the Penicam, we could see here that in fact he had a Salzmann's nodule that was causing his distress and his unhappiness. Performed a superficial keratectomy, and then 6 weeks later evaluate. You can also see this with untreated or unrecognized anterior basement membrane dystrophy. I see this actually quite often on patients referred to me. Another woman was referred. She had cataract surgery a couple of months previously and complained of terrible vision, no previous surgeries. You could see her refraction here. And of course, when we look at the imaging, we could see here that she in fact had unrecognized keratoconus because the referring doctor did not do a tomography or topography. And so she, of course, needed the IOL exchange. An IOL exchange is really nothing to be afraid of. They're really quite straightforward to do, and that can be actually the best thing sometimes for the patient. Of course, if you can do something else, then you don't need to do that, but they actually work quite well. So here's the algorithm for an unhappy IOL patient. If it is a quantity of vision issue, if refractive error is fixed by refraction, an IOL exchange for greater than a diopter, less than a diopter, I prefer LASIK or PRK, and sometimes you need a toric IOL rotation. If the capsule is not intact, then you could also consider PRK or LASIK in this situation. If it's a quality of vision, decide what the issue is. If it's a negative dysphotopsia, usually gentle reassurance helps, and if not, then a reverse optic capture or consider an IOL exchange. If it's a positive dysphotopsia or contrast or glare issue, you can wait a few months. If that's not changed, then exchange, and also check for other pathology. There could be unrecognized anterior basement membrane dystrophy. I see this on a fairly regular basis. Don't forget about floaters or vitreous opacities. A YAG floaterectomy or pars plana vitrectomy can also be very helpful here. And for keratoconics, an IOL exchange for either a monofocal, toric, or small aperture lens can also be helpful for you. This is my algorithm for selecting IOLs. It basically helps go through all of these different scenarios here. And at the end of the day, just like I tell my kids, it's easier to stay out of trouble than to get out of trouble. Thank you.
Thank you so much for that wonderful talk. Now we have Dr. Gaurav Luthra, a master blaster and a high experienced ICL surgeon. And all to you, Gaurav.
Thank you, Sonu, and it's a privilege to be in your course. And Sonu has asked me to speak on managing phakic lens nightmares. And I wanted to start with this, obviously nightmarish situation with a phakic lens. So this patient was referred to me, came to me operated by a colleague who's well known to me. Both eyes were done very nicely. One eye was doing well. This one was having a good vault. Fellow eye was not doing well. The patient was not seeing well, but they had not been able to diagnose what is the problem. So when I did the OCT, clinically it was difficult to understand because the situation, it wasn't a very clear picture on the slit lamp. But when we did the OCT, we found that the ICL was sitting upside down. And this is not a new slide because now everybody's become very careful. This is from almost like 8-10 years back when they just started doing ICLs in their practice. They found that they could not diagnose this. So patient was with me about 15 or 20 days post-op, not seeing too well, about 6-18 types. And I saw that the ICL was upside down in one eye. So I told that patient to immediately get it explanted and if possible, go back to his primary surgeon. Otherwise, I would help him. So patient came back to me about 5-6 days later after having the ICL explanted. But this is how it looked. It was a proper cataract formation and there was a fibrotic ring and there was a central clearing where the lens had given way. And it had become the cataract had kind of melted almost. So I had the difficult task of kind of retrieving whatever I could from this eye. And this is a nightmare situation. So one has to be extremely careful when implanting phakic lenses. Ideally on table, you should be sure that you've got your landmarks right and you've implanted the lens in the correct orientation. It's usually easy to see for an experienced surgeon, but even some experienced surgeons may miss the fact that the ICL opened up upside down unless they are extremely careful. Of course, intraoperative OCT has made a lot of difference and now we can actually see the vaults on intraoperative OCT, but first thing post-op day one should be to look for the vault on the slit lamp and maybe an OCT documentation is a great idea. So that would help. Now this patient, of course, we did the cataract surgery, patient did well. 6 months later went on to develop a detachment in that eye and that was operated and finally, patient was settled. Now this is another situation where I had a lady, 46 years old, who had been coming to me for almost 8-10 years with keratoconus and stable keratoconus, no cross-linking done, but had stabilized over the last 10 years, had very high astigmatism. As you can see, 4.5 diopters in the right eye, 3.5 diopters in the left eye, improving to 6.9 and happy with glasses. Wanted refractive surgery, kept coming to me for almost 10 years. When we did the topography, obviously there was keratoconus, but it had remained, even the topography was stable over the last few years. So we decided that we can take a chance of going with a phakic lens. The AC depth was about 3.01 here in the right eye, 2.92 in the other eye. We did some calculations using the OCOS and then also using the ASOCT based data. And there were two sizes being predicted. One was the 12.6 and the 13.2. Since it was a keratoconic eye, we thought that we might end up using a 12.6 because usually they have a falsely high axial or the anterior chamber depth. So we went ahead with the surgery and luckily we ordered two lenses, 12.6 and 13.2. And so it was a routine surgery. We implanted the ICL. This is a 12.6. And once that was in place, we went with the AIOC and you can see that there is almost no vault. It's just about 50 to 100 microns. On the right side, it's not a very clear picture, but you can probably make out a little bit that the ICL is sitting somewhere here and this is the crystalline lens. So there's just about 50 microns between them. So obviously this ICL would not stay there. Now, if we did not have access to an IOCT, we would have never known that this vault is solo except unless, on the next day or maybe post-operatively on the slit lamp. So luckily we had a second lens with us because we had been trying to decide between the 13.2 and the 12.6. So on table itself, we decided that we need to explant this lens and put in the 13.2. So we went ahead. And after this ICL is out, we implant the 13.2. And finally with that we got a better vault, and you'll probably be able to appreciate that on the right side. It's not a very clear picture for some reason, but the vault was much better. Post-op documentation showed about 330 microns in both the eyes. So both eyes eventually got a 13.2, and patient did well. Now this happened to us about 2 years back, and after that what we started doing is then now we order 2 sizes for each patient, and on IOCT we decide whether the vault is to our liking or not. If we find that the vault is either too high or too low, we can downsize or upsize the lens. So that has helped us give our patients a better result. Now this young lady was post-ICL almost 10 years, and during COVID times came to us with post-COVID vaccination, bilateral uveitis, and a very severe one at that with hypopion. Treated adequately, went lost to follow-up because she went back to the hills. Came back again 6 months later, with this time with again uveitis with intumescent cataracts in one eye, and the other eye also with a very significant cataract. Again, we ended up almost with an iris Bombay in one eye. So we did a laser iridotomy, which expanded to become quite big. And finally, of course, the inflammation became quiet over a month or 2. Then we took up the patient for surgery, but by this time, this lens was very intumescent. So for cataract surgery, there's a pupil which is not going to dilate beyond this. There are some synechias, and there's an ICL sitting there. So ICL, phakic lens eyes don't do very well with inflammation. If they have inflammation, one has to treat them very aggressively. Otherwise, they tend to get complicated very fast. So if there's an attack of uveitis in a patient who has ICLs in situ, one must intervene. One must treat them adequately and promptly. And in some situations, if the inflammation is not settling down, it may be a good idea to even remove the phakic lens. So here under infusion, I am trying to get this ICL out of that smaller pupil. So I'm negotiating it out. And once I get one haptic out, then the other one, and then of course both of them. Now I'm going to stain this capsule under the ICL. I don't want to put in viscoelastic till I've stained the capsule nicely. So I go under the ICL and stain with trypan blue and get the ICL out. And now I want to, because it's a very intumescent cataract, I want to decompress this lens. So I'm going in with a 26 gauge needle on a 1 ml syringe. I will puncture it and try to aspirate whatever I can very quickly. So please keep watching, and then that's the plan. And the moment I touch it, it just goes into the Argentinian flag sign. Now it's of course a soft cataract, but you can imagine the kind of stress. It might have just ruptured on its own if I'd left it like that for some time. So I salvaged the situation here, and this patient was planned for a toric lens because this was a high astigmatism, but I think eventually we didn't put a toric lens. Fellow eye, we thought that this is a lesson to be learned, and we decided to go with a femto-assisted surgery. Fellow eye also had a flat vault with a fairly advanced cataract, and we went with the femtosecond laser here, and as it starts scanning, you'll be able to see that the laser does not detect the ICL very nicely. This is the ICL sitting over there, so the corneal parameters look nicely, but you can see that it's picking up the iris incorrectly. It's picking up the iris plane on the ICL plane, and it actually picks up the optic of the ICL as the pupil, so then you have to rearrange the landmarks so that it fires at the correct place, because otherwise your capsulotomy won't be perfect. So I've rearranged the anterior capsule lens and the posterior capsule landmarks properly, and then you can fire the laser. So this makes life much easier, and then now you have a rhexis in place. Most often the rhexis comes out well, sometimes it does not, and I'll just show you a case how it does not. After this, it's a cakewalk. You just get the ICL out, and then you go ahead with the cataract surgery. It's fairly straightforward. Now, this is another patient who was with phakic lens many years old, and I'll finish very quickly now. Underwent a VR surgery, and following the VR surgery, following the SOR, this lady developed a cataract and now needs a cataract surgery. So you can see the silicone oil bubbles here, and we thought that we will prefer a femto-assisted capsulotomy here, and went ahead with the usual way that I showed you. We are getting the landmarks right, and as always the ICL gets picked up like the pupil. So once I have all of them right, we fire correctly, get the ICL out. Now once the ICL is out, you have to just go ahead with the cataract surgery, but what we find is that the rhexis is not good. So you can see here that the rhexis is not complete. Now, the reason why the rhexis is not complete is something we didn't know before this case. It was incomplete because of the silicone oil bubbles in the chamber. Silicone oil is not penetrated by the femtosecond laser. So when you have oil bubbles in the chamber, never use the femtosecond laser for your critical steps, because they will not be able to go through the oil, or else you can wash out the silicone oil first and then use the femtosecond laser if you must. We did manage to get away because we had to complete the rhexis and everything. But after that, we also had to deal with this bad plaque which had developed. And we literally had to peel it. You can see how tough it is. And I'm trying to make a plane with manual dissection. And you can see that I'll try to go on one side, then the other side. And because if I leave this here, I'll have to come back and do a YAG later on, or a primary capsulotomy. So I'm just getting under the plaque. You can see the stresses on the posterior capsule, because if I pull too much, it will just lead to a zonular dehiscence. But I managed to create almost like a smile kind of a pocket. And I'm sure Sonu Goel is liking this because he loves to dissect his smile planes. So I've created a smile-like dissection plane. And then I just remove it with a forceps, I think. So once I've done that, I'll just hold this. Then I keep peeling from one side, then from the other side. And eventually, without having a break in the posterior capsule, I'm able to get that plaque out. So with that, I'll stop. Thank you so much.
Thank you, Gaurav, for that wonderful sets of nightmares. I think very wonderfully elaborated. Just a quick question by the time we have Kamal on the stage. What's the lowest vault that you would like to explant if you have a surprise? And
so if it's a toric ICL, I will definitely have less tolerance for a low vault, maybe anything below 100. Now, if it's a toric ICL and sitting right, it's not rotating, I will let it be even with a very low vault, maybe 100 or even say 70, 80 microns. Because I have a few patients on follow-up now who've not gone on to develop any cataract even after 5 years. We had offered them an exchange, but patient is doing well, he's 6'6", unaided. Eventually, of course, there's a chance he will. So it's a very difficult decision, but you have to discuss with the patient and give both the options to the patient and tell them that, an exchange might be beneficial to you. But I've been in a funny situation. There's a patient where I had a patient with about 50, 60 microns, and I told them that we'll do an exchange. Now, I upsized by only one step, which means that from a 12.6, I went to a 13.2, and I don't like to use the bigger sized star lens. For this, even after the exchange, the vault remained at about 80 microns. So a patient asked me that, why did you exchange my lens when my vault is going to remain the same? Now, this is probably because of peripheral zonular issues, right? But eventually, so frankly, if the lens, I'll keep these patients on close follow-up, like maybe every month or two for initial things. If I start seeing some early cataract change, for one patient, I recently did that. 1 month down the line, we started noticing some very early changes. I've gone ahead and, done the ICL exchange, but this time I upsized by 2.
thanks, Gaurav, for enlightening us. So I think after learning everything about the ICL surgery, how do you start your practice without those fancy gadgets? And here is Dr. Kamal Kapoor, who will be sharing his experience setting up Phakic IL practice, how to build up. All to you, Kamal.
Thank you, Dr. Sonu. I think a lot of stalwarts have spoken before me. So I will just take you through the journey of having a mindset to do phakic lenses. So can we have a show of hands? How many people here are doing phakic lenses? Wonderful. And how many of us are doing phacosurgery? And how many of us are doing refractive lens exchange, which is equivalent to phacosurgery? So I think by the time I finish, we'll change these figures. So whenever you start a new phakic IOL practice, there is a confusion, there is unsurety. That's all because of lack of familiarity. So let's plug in and open our minds that what is the basic procedure called phakic IOL. Let us see what are the options available for refractive surgery. Of course, LASIK, PRK, but of course, you have rate limiting. You cannot do it for very high powers. Refractive lens exchange, yes, but it's a little controversial. I just did a session with Dr. Alio upstairs where I talked against refractive lens exchange, especially for myopes. Of course, it's a procedure of choice for your hypermetropic patients. And of course, phakic IOLs. Now, let's open our mind, as I said. you can do phakic IOLs even for your low-powered patients. So for all of us who do not have access to heavy-duty LASIK machines or SMILE machines or PRK procedures, you have something which you can offer your patients for refractive correction without resorting to other procedures. Now let us understand the difference between LASIK, the functional difference between LASIK and doing a phakic lens. It could be an IPCL or an ICL. Your cornea remains untouched, tear film remains untouched. You can actually do large pupil size procedures because a lot of Indian manufacturers are making large sized lenses. No high order abrasions induced, as my friend Dr. Pooja said, no biomechanical weakness to the cornea. IL calculation for future will not be altered because you have not played around with the keratometry. You are not restricted from not using multifocals at a later date. IOP measurement will not be altered because your cornea thickness is not altered. Effective optical zone is bigger. So phakic lenses have a practical advantage over LASIK also in your practice. There's no dependency on heavy-duty machines, no borderline topography. All you need is just an optical biometer or a simple topographer. And in case you don't have access to that, let's see what else can we do for these patients. So what are the factors in favor of phakic lenses? It's a reversible procedure. You can reverse it. God forbid something is not okay, patient is not happy, you can reverse it. You can top it up, you can reverse it, exchange the lens, you can do an enhancement. There are no postoperative dry eyes, there is no IOP measurement problems. So these are the issues which you don't need to deal with if you jump to a phakic lens practice. Complications of LASIK, of course, they are rare, but yes, you can avoid all these. Now, what are the complications with phakic lenses? Yes, let's see. An improper power, you can reverse, you can explant. Vault induced is high, you can explant. Vault induced is less, you can change. Refractive error, you can change. Malposition rotation, you can change. Iridectomy or angle closure, you can explant the lens. Cataract, God forbid you have a cataract, you can still help the patient. Unlike all the other procedures of refractive lens exchange, you have done that procedure, you cannot reverse it. Endophthalmitis, of course, is very, very rare. I have very large series, probably I think one of the largest series in the country in phakic lenses, especially the IPCL. I've never seen an endophthalmitis. Now compare it with the phakic refractive lens exchange. Advantage is, as I said, it's a reversible procedure, absolutely. All the risks of endophthalmitis, choroidal hemorrhage, vitreous loss, posterior capsular rupture, none of them are seen with the phakic lens. So starting a phakic IOL practice, all you need is a basic skill of a phacosurgeon, a good quality autorefractive keratometer to start with, which has got good imaging system, a digital caliper machine, optical biometer would be excellent if you have it. In case you don't, you can also do with an immersion biometer. A good quality ASOCT machine. You may have access to a pentacam or a Cirrus with your friend, that will really add up to the whole system. So this is probably, we've done more cases till now, 4,000 plus phakic lenses done and counting, corrected any power you can dream of, any astigmatism you can dream of, customized lenses we've implanted. So it's a beautiful procedure, even in a beginner's hands. Few things which you need to take care of are selection of the right patient, workup investigation, surgical steps to be taken care of. So patient selection. Whenever you see a myopia, don't jump to a phakic lens. You could be having an early sclerotic cataract even in a young patient. I remember 4 years ago, I had a young Sikh gentleman came to me with -4, and one of my junior surgeons posted the patient for me, but I, as a habit, always want to see the patient dilated. I want to see that dilated cycloplegic refraction. When I dilated the patient, he had early lenticular sclerosis. So he was a candidate for a refractive lens exchange than a phakic lens. Evidence of nuclear sclerosis, anterior chamber depth has to be more than 2.8 millimeters. For a beginner, I would say a 2.93 millimeter is a decent size because you need to get your nomograms right. History of uveitis, glaucoma, shallow angle, mid-dilating pupil. Now, beginners should avoid pupils which do not dilate because they can be tricky to put the phakic lens first. First, go in for pupils which have large, they dilate well. Any history of retina detachment, keratoconus, avoid as a beginner because keratoconus patients will give you a false anterior chamber depth. You will think that you have a high anterior chamber depth, but the periphery is going to be shallower and you will have crowding of the angle. improper size and all these. Now, these are the powers available. In fact, more powers higher. I think I have the highest record of power corrected, minus 38 with 4-cylinder in myopia. So most of the lenses I use are these two. ICL is available in 4 sizes. IPSL is available in 30 sizes. You can have a customized lens made for you. So sky is the limit. I'll give you some basic outlines. Do a cycloplegic refraction, a very accurate refractive cylinder acceptance. In case some of these patients may have, latent squints, please mention it. These patients may be amblyopic, mention it. Look for lenticular changes. How to do the white to white? People say vernier, digital caliper. I would say digital caliper should be your second method of reconfirming. In case you have an access to a Pentacam or a Cirrus, use them. In case you don't, you can send this patient to your colleague, do that. In case you don't have any of these, you can use a simple auto refractokeratometer which has a built-in pupillometer. We will just go to that. Now, sizing up, as I said, angle measurement is very important. You should have an access to an AIOC. You should have a good, decent angle of at least 35 degrees of angle horizontally before you venture onto this journey. Measuring of pupil is very easy. This is an image from an autorefractokeratometer. Do not start with very small pupils or very large pupils to start with. The optical zone of the pupil you measure is approximately 1.25 times multiplied the actual optical zone of the pupil. Anterior chamber depth is very important. This is the distance between the endothelium and the crystalline lens peak. Now, this is the anterior chamber depth. This is the vault. The distance between the crystalline lens and the back of the phakic lens is your vault. 2.8 is the bare minimum. Now, in case you don't have any access to fancy equipment, you can do 3 or 4 readings of your immersion biometer, take the anterior chamber depth, subtract the tachymetry as on your AIOC from that, and you get a decent value. So for that, I give a cutoff of 2.9. Don't go for 2.8 because you may have some errors here. What in case you have 2.8 millimeter anterior chamber depth? Is it okay? Yes, it is okay, but sometimes it can be wrong. You could have a bad angle, you could have an iris cyst, you could have a keratoconus, you could have a very high lens rise. Now, this is what happens to the angle when you actually put in a phakic lens. You see the angle here. The angle is 50 degrees. Post-surgery, it is 35. So we've seen that the angle goes down by 15 to 20 degrees after placement of phakic lens. Ideally, if your phakic lens is vaulted by 600, 700, it will go down by 15. If the phakic lens is more vaulted than 800, it will go down to 20. It will go down by 20. White to white measurement using of the vernier caliper. Of course, this is very easy. This is a very cheap and a simple instrument. Use this to confirm what reading you got on your biometer, autorefractokeratometer image. This can serve as a counter check. You can measure this. This is how you use the autorefractokeratometer. Use 3 or 4 readings. Over time, you'll get a hang of it. If you're using a Pentacam or a Cirrus, do a manual override for that. I think I'll skip this. Yeah, this is important. In case you have high astigmatism, I recommend do a vertical white to white also, because sometimes you could land up with a vault which is unexpected. Another concept is a concept of CLR, which Dr. Sheetal mentioned. We were the first ones to mention it 11 years ago. And that is also very important, but that's beyond the scope of my talk here. Phakic lens sizing is you should have approximately 1 to 1.5 thickness of your cornea, which is approximately 500. Lowest vault should not be less than 250 for a beginner, but as Dr. Gaurav said, I have patients who are doing less than 200 and then doing absolutely fine. I have patients who are doing 1100 plus vault, they are doing fine. All you need to do is keep these patients in check, keep them under monitoring. Now, in case you're planning a toric lens, you can plan one size bigger because it makes the lens non-rotatable. Especially if you're using the Indian lenses, they give you a decimal 0.25 size. Every 0.25 size you plan higher, you go up by 100 microns to 150 microns. So if you got 500 microns in one eye, second eye planned to a 0.25 size, you will get 650. So for every 0.25, my nomogram is anything between 100 to 150, you will go up. This is the worksheet which mentions your anterior chamber depth, your angle, your keratometry, everything. And this is what you can do to simple for people who don't have fancy markers and online markers. You can just use the slit lamp, angulate the slit lamp, make the slit beam longest and thinnest, turn the slit to 180 degrees or 0 degree, whatever you want. Ask the patient to look straight into the light, and all you can do is just mark. So this is simply starting the practice. Yeah, I think this video is... Yeah, so mark with your pen. You can mark the 0, 180, and you can have your reference mark. Yeah, this is how it looks like through the slit lamp. First orient the straight. Now go in for marking on 0, 180, one spot, second spot, and there you are. So you can do this in a basic setup, and you can start your Phakic IOL practice. Thank you.
Thanks, Kamal. I think aao acha dekhe. So that's the entire theme and very well depicted of setting up a private clinic. So we are running out of time, and I'd like to introduce Dr. KP Kudlu, a member of the GC and editor proceedings. All to you, KP.
Thank you, Sonu, for the opportunity. Thank you, Sanjay sir, letting me go earlier. Thank you, all the panelists. I think most of the people are genius in Phakic IOL, so my job has become much, much easier. No financial interest as far as this presentation is concerned. So I think all these factors, patients who are not suitable for LASIK, all these factors I'm not going to talk. So I'll be telling few features of the ICRIC Phakic IOL, which has got excellent visual outcome, easy to load, easy to implant, and presence of both central and peripheral hole, and very less chance of flip and rotation. So what are the advantages with these lenses? We all know that which is far from the endothelium and close to the nodal point of the eye, stable location, does not alter the shape of the cornea, and which is completely reversible. So these are the A list. Already all our previous speaker has been done about how to know about ACD. But this is one point I wanted to tell. We did one comparison. The most accurate ACD will get either from A-scan or IOL Master 700 or best is ASOCT. So A-scan is comparable with ASOCT and IOL Master 700. But I always do with the ASOCT or with the A-scan. Then white to white is the single most measurement which has been bearing the success of the procedure. 2 to 3 reading normally we take. Oversizing causes a high vault, which causes glaucoma. Undersizing causes lower vault, which causes cataract. Again, we have done one small study, which is the best of the for white to white. If you calibrate digital caliper, that gives the best of the best result in comparison with the old model of orb scan. So undersizing causing low vault, as I said that, long-term effect, it can cause a cataract. So if you see, we have done some of the, one of the, just now Sheetal Brar has left from here. She has presented compared with the vault of star ICL with the ICRIL Phakic IOL that showed the mean height of the central vault showed reduction over time, but none of the eyes in either group developed cataract due to the low vault. So both the results are comparable, both star ICL with the ICRIL Phakic IOL. So let us come to the lens changes for a longer term. So as I already said that if there is lens changes, again it is depending upon if there is a low vault. So as the age progresses, lens keep changing also. But if you are having a high vault, always you can expect them to have a glaucoma. So because high vault, there is a mechanical contact between the ICL and the iris, mechanical compression, shallow AC, inflammation, high IOP, angle closure glaucoma, and that gives to pigment dispersion syndrome. See, these are the complications can happen with the high vault. So I am not going to talk with any of this point. So these are the one point I want to take. We need to look at the long-term effect on the corneal endothelium. The rate of endothelial cell reduction in normal eyes is between 0.6% per year. Thus, endothelial cell loss after Phakic IOL implantation mainly a result of surgical procedure itself, not with the Phakic IOL implantation. So you need to remember. So average of 6.2% of endothelial cell loss was reported in 8 years of following ICL implantation, one of the study from Igarashi et al. But some of the other studies shows that, Toran et al. Studies show that 5.8% of the endothelial cell loss average 7 years after the PRL implantation. So this is about the how even it can happen with a patient with a chronic uveitis too. So regression, of course, normally as the age progresses, the regression can happen. The Igarashi noted that significant myopic regression after ICL implantation in 8 years follow-up study. Similarly, other study shows that myopic shift 7 years after the ICL implantation. So long-term predictability regarding the Phakic IOL implantation, long-term predictability, 67% of the eyes were within 1 diopter of attempted spherical equivalent. The reason why 33% were outside the scope of 1 diopter of the attempted correction could be caused by generation of myopic regression. So of course, long-term of risk of RD is mainly due to the RRD is caused by the pathophysiological alteration, that is high myopia, rather than a complication with the implantation of posterior chamber PCI, phakic IOL. This people has to remember. So the other complication with the myopic CNVM, which is the high incidence in the high myopic, the one of the cases report that CNVM 4, 8 or 10th year after the ICL implantation, because that is due to the pathological myopia, not with the ICL implantation. Of course, induction of corneal astigmatism, I want to compare normally ICL will go through the 3-point incision where the phakic acryl phakic goes to the 2.8 incision. We need to study the level of astigmatism induction will be much lesser with the acryl phakic lenses. This is about the rotational stability. Normally rotational stability occurs for 5 degree in 17% of the patient, then less than 10% were seen in 3 years in most of the cases. That is again with the, not with the cases, the report are with the rotation stability both equally with the ICL and the other lenses. So these are our experience with the acryl phakic regular one, 200 patients. If you see here, I think this is a hydrophilic material. You see patients, most of the patients are between the range of between -10 to -15 diopters. If you see 46% of the patient has got a spherical equivalent between 0.5 to -0.1. Then wow factor, if you see almost around 95% of the patient, and 20/16 almost 90% of the patient. So again IOP stability is almost normal. So as I said that patient achieving post-op uncorrected equal or near to the preoperative best corrective visual acuity. Endothelial cell loss was around -3.1. And also none of the patient developed cataract or iris deformation. None of the patient required IOL explantation also. Only 18 patients had an initial rise of IOP which has been controlled by medication and equally stopped. These are a few results of our acryl phakic toric. So 132 patients, these are the, I am not going to talk about the different models. So this is the overall results. Patients coming after 6 months of follow-up. If you see here, more than 95% of the patient had a refractive astigmatism less than 0.5 diopter. That means the rotational stability is very stability with this patient. 88% had a less than 5 degree rotation and all eyes less than 10 degree rotation. That you could able to see. In conclusion, acryl phakic and acryl phakic toric IOLs are phakic lenses are safe and effective for treating range of myopia and myopia with astigmatism. Short and easy learning curve for cataract surgeon. Quality of vision is always better than promise. Again, I thank my brother Sonu for this wonderful opportunity. Thank you one and all.
Thanks, Kudlu, for bringing out that long-term outcomes. I think that reassures us that over 20-25 years that we have been using this lens tests the stand of time. I think that's quite reassuring. Thank you very much. And now we have none other than Dr. Sanjay Chaudhary. I think he is one of the largest ICL users in India and the most experienced of the entire gamut of surgeons in India. So he'll be talking on vault. How much is safe? All to you, sir.
Thank you, Dr. Sonu. So first, let us say there are two things which are important when you're doing an ICL implantation. One, how do you do the sizing to get the right vault? And second, what if you have not got the right vault? What would you do? So here I would be talking about situations where the vault has not been right and you have to do something about it. What? Let us see. So this is a normal vault, 500 microns, which is 1 corneal thickness. And we say the vault should be 500 microns plus minus 250. That means 250 to 750 is a normal vault. these days we say 250 to 1000 is the normal vault, because it is good to have a little more vault than a little less vault. The reason being that the lens becomes thicker with age and the vault decreases, not because the ICL position is changing, but because the lens is getting thicker. So that is why a 1000 vault is now considered a good vault. This is the protocol of safety given by STAR, which says if the vault is less than 100, try to look if there is a central touch. If not, let it be. If it is between 100 and 250, naturally you would not have a central touch. Try to look for a peripheral touch. If yes or no, just keep monitoring. 250 to 750 is just the right vault. Probably now 750 to 100 is also the right vault. And only over 100 are you supposed to be looking whether I am going to be in some kind of a problem or not. So this is a shallow vault. Vault is 212. We did an ASOCT. There was no central or peripheral touch. The ICL itself has a vault of about 80 microns. Because there is a central hole and there is aqueous flowing under the ICL, between the ICL and the crystalline lens, even in a shallow vault. So the crystalline lens is continuously being bathed by fresh aqueous. So the lens is safe. And one really does not need to think of removing the ICL even with a very shallow vault. Just keep observing. As long as the aqueous is coming under the ICL, the aqueous is kind of lifting up the ICL to some extent. And we are just observing, and normally for years together, nothing ever happens. However, here I am showing you a case. If you see on the left side, the ICL is touching the crystalline lens. It's a shallow vault. And to get a better picture, I dilated the pupils to show you the whole anatomy of the ICL to the crystalline lens. It's very shallow here and it's touching at this place. This was a lens which did not have a central hole at that time. If it had a central hole, then there would have been aqueous flowing between the crystalline lens and the ICL, and this kind of a touch should not have been there. But anyway, even after this touch, it took 5 years to get that little cataract there at the periphery. And look at on a slit lamp, this is how it looked in the periphery. Now we were wondering, it was new to us, it was right in the beginning, say 15, 20 years back when we started these lenses, and we really didn't know what to do, and there was not many people to guide us how things would be. So still everybody said that now that there's a cataract, you have to do a cataract surgery, so might as well wait and see what happens. So it took another 5 years for the cataract to come to a little distance in the middle, and that is when we decided that we'll do a cataract surgery. The patient didn't mind. He had enjoyed the best part of his life, 10 years without glasses, had a very high number, and the surgery was uneventful. More concerning is the high vault. Like this here, and if you see like this, there's barely a threadbare gap between the underside of the cornea and the front side of the iris. These situations are a little difficult situations. Now, here see this. The vault is 1456. And still, the angle is about 10 to 15 degrees, 10 degrees. So, as long as the IOP is normal, ASOCT, most of us has ASOCTs now because all of us are doing OCTs for the retina. So, ASOCTs for the anterior segment, pupil size is normal. You don't have to do anything about it. Let it just continue. Just keep monitoring it. When do you really need to do an ICL exchange? You would do an ICL exchange when these problems are happening immediately. One, there's a high vault with angle closure in any one quadrant. ASOCT, you can see there's an angle closure here. The rest of the quadrants are open. So this merits immediately ICL exchange to a lower size. High vault with a large pupil. Now what is so special about a large pupil? When the vault is high, it's pushing the iris forward. It could be enlarging the pupil. The contact between the iris and the ICL is strong. And if the pupil gets enlarged, its contractibility also reduces. And that is when people with large pupils will have a lot of glare even during the day. So in such cases where the pupil is becoming large, severe post-operative night glares, even at daytime he could be having a lot of glare, it warrants a lens exchange. And you keep monitoring the endothelium. If you think there's a slight endothelial loss, you can monitor the patient for 1 year and then take your call. Now, why I tell you that even if it is a high vault, you should not be rushing into the ICL exchange. The reason is that the vault comes down with time. Now, if you see this, this started with as a vault of 1568. And at 1 month, it was more or less similar. At 8 months, it is 1300. And at 1 year, it's even gone down further. And the vault came down by 390 microns, 400 microns in 1 year. Not bad. So I didn't need to remove this lens at all. The question is, why does the vault come down? There has to be a reason. And the reason is that the ICL is tight. It is supported on the ciliary body. And it's pressing on the ciliary body hard. And the ciliary body is a soft, spongy tissue. So as it keeps pressing hard on the ciliary body, it kind of dents the ciliary body and spreads out. And so the vault keeps coming down to a certain level and then it stops. Now, vault is usually a problem when the white to whites are small. Because, an example here, if the white to white is small, a little higher size is certainly going to raise the vault very high, and a little lower size is going to make the vault come down drastically. So see this, the white to white was 11.1. We did an ICL size 12.6, and look at the vault we got. Terrible. And the left eye also, we got a vault of 1376. In the right eye, we got a vault of 1400. So we said, okay, this warrants an urgent exchange. So we took out the lens and replaced it by one size lower, from 12.6 to 12.1, 12.7 to 12.1. And see what happened. The vault in the right eye became perfect and it came down by 666 microns. And what happened to the left eye? Just by reducing one size lower, the vault came down to 1100, it reduced by 1100. See the level of fluctuation. So, it is the high vault which is more worrisome and not the low vault. Thank you so much.
Thanks, Dr. Sanjay Chaudhary, for that wonderful description of the vault. So, I think that brings us to the end of this wonderful IC. And without wasting much time, we have the next session, the APO award session. So, thank you very much.